Hello, everyone. So you might notice I look a little bit different in this video than my other ones. I'm recording this one a year later, so hopefully I still can remember some of the stuff. I think I do. Um, the reason I'm re-recording this video in particular is twofold. First, I got some feedback from some people that I didn't share the screen. So they had a blank screen the whole time, and I really wanted to re-record this so that you had the video with the slides being presented. I tried watching it. It's way harder if you can't see where I'm trying to show the mouse. And the second reason was, as I went through the video series, I actually changed how I was looking at Q waves, ST segments, T waves. And so I really wanted to update this video to kind of reflect that change. I found that the way I was doing it the first time I recorded it was a little bit harder than how I was doing it near the end. So perhaps give you the way I'm currently doing it from the start might make this easier lesson. I will keep the previous lesson. You're going to see it. I'm going to keep the previous one up just in case there are some things that I might have just said differently because I was recording it as a whole series. And understandably, there might be things I said in that recording that I wouldn't have said in like this recording in the same way. I did rewatch it, so I'm going to do my best to be as true as I can to the overall flow. But of course, recognizing it's been a year, so there might be some changes here and there. So I'm going to do the usual thing, share the overall approach, and I'm going to make sure I reshare my screen to show the slides as well. So starting with the Word document. Oh, I think I might be sharing the wrong Word document there. Let's share the right one. Share this guy. So what are we looking at for today? So we're really focusing on the Q waves, ST segments, and T waves. So this is this section right here. So if you're underneath the first section, it's 0.8. And then on the lower ECG guide, we're looking at these two areas for kind of like your hints about how you practically use the criteria. So ischemia and infarction. So if you want just a quick overview of what this lesson's based on, it's that. Now we're going to pull up the slides with, the images from Lily's cardiology. I'm going to have my speaker notes open just for the sake of helping me keep it a little bit more accurate to the material I want to present. Okay, so Q waves, ST segments, T waves. And credits to U of A. I think, it's Dr. Sonnenberg. When I was in the course, he did a great job. And so this is just giving you a different view of how to read ECGs. So outline for the lesson is ischemia and infarcts, looking at ST changes, Q waves, and infarction criteria. Then we're talking about ischemic criteria. It's a little bit different, but not too much. And then T wave changes, which I think when I remember going through the class was something that was frequently kind of like questioned, especially when I was practicing with friends. And what we kind of came down to saying is that if there's a depolarization abnormality because a piece of the heart tissue died, there's a repolarization abnormality with T waves being changed. But you have to interpret them after you've read everything else. I'll go through this as we go through the lesson. Then we'll briefly review the approach to the ECG, the rare steak barbecue. I changed this a little bit with Sterling, so we'll come back to that. And reading 12 leads, just the grouping, getting used to, the lateral leads, inferior leads, anterior leads. And then a little bit of practice at the end. So the week 4 ECG stuff from assess.med, both sections. So there's a few questions and one question from the other one. So myocardial infarction, Q waves. When we're talking about a Q wave, the idea is that you want to think timeline. So just because someone's heart tissue is not receiving blood, so it's ischemic, doesn't mean it's died yet. And once it's died, it doesn't exactly look like the end result right away. It takes time for the changes to occur when you're putting leads on the person. So if you have a normal ECG, you're seeing this nice R wave and there's the T wave. Of course, there could be a Q and an S, but here it's just the R. Right after the person's heart starts to go ischemic, we see the R wave and we see this little kind of jut. So this was this PR segment. So this is the baseline. This is the TP, so kind of going over to the atrial contraction. Then we have the R wave, but then this ST segment is above this PR segment. So I always looked at the inflection, so where it changes kind of going from one direction and it shifts to like a little bit different. That's your ST, that's kind of your J point or ST change. So you can see it's higher from baseline. Then we have the T wave there. And then if we looked over here, we see this Q now suddenly appearing, this R, and then we see this ST still high and it goes over. And we still, ST is high, it's Q is getting bigger. And now we see Q is definitely like quite large. This R isn't as big as it used to be. And now the ST is gone. So what that means is that ST segment is an acute change. So if someone's showing up into the ER, they have chest pain, they're diaphoretic, they're getting syncope, you're looking for an ST elevation to start, not a Q wave. So that's the thing to realize there. Q waves occur, so this is normal, acute, so within minutes to hours, and then a day. So Q waves don't really start to begin until hours in. So there's still time to save the heart before then. Once this Q wave begins, it gets bigger and bigger, and then it just stays there forever because that piece of heart tissue has died. So now we see it in the ECG as a Q wave. The other thing that is important from this picture, there's quite a bit in here, is we see this T wave. So we see this T wave going up, we see it going up, oh, and here it goes biphasic. So around day 1, 2, it goes up and then down. And then it gets inverted days later, and a week later, it's back to normal. The thing about the T waves is that they're so non-specific. They are seen in so many different conditions, and they're always, it feels like, each one has something that overlaps with the other. That's why you don't start with the T waves. I would start by looking for the ST elevation, then you're looking for the Q wave, then you're looking for any T wave changes. You're not starting with T waves. It'll be very confusing if you do. Yeah. And the other thing I wanted to say was that just because you're seeing a biphasic T wave, it's not specific in itself. It just means it's been longer since that piece of heart died, because you don't see it initially. You don't see it till day 1, day 2. Aside from that, there's not too much to get from it. Same with the inverted T waves. Again, it's later. So Q wave changes. So what a Q wave means is that there was a previous MI. It's not the current one, well, unless it's done, but anyways, it means that piece of heart tissue is now dead. So it takes several hours to days for development. So you're not using it to look right away. And basically it's the change in electrical activity. I have some slides that actually show what that looks like. So there's the words for it. I'll show you in a picture. Persistent definitely unless immediate intervention. Just because there is a start of a Q wave doesn't mean it's going to be there forever if you reperfuse the heart, but you need to do it quick. What you're looking for in an ECG. So if we're looking, this is normal. So then we have our Q, this is our R, there's no S. And then over here, this is a much deeper Q, then there's an R, and then there's no S, and then we're going over here, ST segment. So what we're looking for is a prominent greater than 1 millimeter width. So one small box width Q wave. And that height, the quick rule of thumb is that it's a box wide and a box deep. That's the quick rule of thumb. And if you want to remember it like that, that's great. The more specific one is that the height is about a quarter of the R wave or the QRS complex. So you see the Q and then this R, and it's like the Q is almost taking from the R. You can think as the Q gets bigger, the R gets smaller. So it actually starts to like essentially overcome it. Let's go to the next slide. So just focus here right now. So where the mouse is. Let's pause this for a second. Now we're good. Okay, so if we're looking at Q waves, so we're looking at the width greater than one small box, so 0.04 seconds, and the depth is about greater than a quarter of the total QRS height. So you can see this is normal. You can see this one is that box wide, about a box deep. That's the shorthand I like to use. There are some other things about here. So this one's probably not quite as high yield. There has to be multiple Q waves in like contiguous or beside each other leads. So if you see a Q wave in just one lead, it doesn't mean anything. It's just one lead. But if you see them in two leads, like one in AVL, those are both lateral leads, and that tells you that there's been an infarct. And if there's a left bundle branch block, don't try to interpret it. So this is the grouping. So 2 in AVF would be the right coronary artery. V1 and V2 are the left anterior descending. V3 and V4 are more the septum, but still left anterior descending. V5, V6, 1 AVL, those are all the left circumflex artery. And posterior would be like V1, V2, but with a high R wave instead of a Q wave. Once you start practicing this, though, you get used to grouping the leads and you just recognize there's an infarct in that area. What was that area? It's in the left side. Okay, what artery supplies it? Left circumflex. And so this picture, I have a next slide, which I think shows this a little bit easier. So if we're looking, so if there is dead heart tissue on this left ventricle here, then as the heart starts to depolarize, so this is how the slide is going, it's going like this. So it depolarizes, and so we start to go away, so we get a little bit of a Q wave. And so what happens is this dead heart tissue doesn't start to depolarize. And so when you do that, you get a positive charge pushing towards the lead. So right here, the positive charge is still pushing away from the lead, so we still see Q. And it doesn't ever point towards the lead because there is no heart tissue to depolarize. So it still pushes away from it. So you still have this kind of Q. And as it starts to kind of come around, then we get the R. So the dotted line represents the what it should look like a normal R wave, but instead, all the charges were getting pushed away from the lead, or at least kind of perpendicular to it. So instead you see a Q wave. So the end result is that you get a Q wave instead of an R wave, and it's a box wide, box deep. And this is just another picture showing what I'm talking about with the charge getting pushed away from the lead. So if there's full thickness ischemia, so the heart tissue is going to die if something's not done. ST elevation, it's usually 100% blockage of the coronary artery. And essentially what we're saying here is that when the heart is kind of relaxing, like the positive charges are kind of pushing away from the lead, so you're going away. But then when you're contracting, the positive charges are actually kind of pushing towards the lead. So just a second here. Okay, so I'm just going to try describing this a little bit differently. So this is kind of talking about the ST elevation. So the initial part that we see, someone comes to the ER, minutes to hours. The heart is always kind of, you have your cells, and so then you have, each cell has a charge in it. And so we always have a negative charge in our electrical cells. So when we depolarize it, positive charges come in, your sodiums, your potassiums, stuff like that, calcium, floods into the cell, and that causes the positive charge in the cell to basically reach a threshold, you fire an action potential. So we call that depolarization. Then when it repolarizes, that positive charges, potassium floods out of the cell, and then that causes like a repolarization, so the cell becomes negative on the inside. So right after the heart is relaxing, so the heart's relaxed, the charges should be, so essentially if you're in relaxation, everything should be kind of going back to repolarization. So it should be getting negative. Problem is when the heart is relaxed with a scar, basically it's kind of stuck in this middle zone. So it's not really moving charges out, it's not moving charges in. So it's always a little bit different than everything else around it. So when the heart's relaxing, everything is supposed to be negative on the inside, but the scar didn't know that, it didn't change. So it stayed positive. And because of how the heart is now all ready to fire, it's polarized, it's got a nice negative charge. This guy who didn't polarize correctly, he kept some positives, is pushing the charge away from the electrode. So what happens is you get this baseline here, this is the baseline now, at this section of the heart. And then when the heart goes to contract, all those positive charges are now supposed to be flooding into the cell, but the scar, it doesn't know that, it stays with only some positive charges. So instead of kind of getting all the charges to kind of equalize, you're left with some negative there, and that pulls a positive charge towards the electrode, which means this ST area becomes elevated. All of this is just to say, like, in a full thickness, like what we consider like an MI, is you see ST elevation. So the simple way to think of it is just think of it, ST elevation is a heart attack. It's really simple. This table is showing the different waves and some of the criteria for infarction. Yeah, you can read it on your own time. It's a good table. So ST segment changes. So MI, oh my. Anyways, so ST changes should be taken in context with clinical findings, blah, blah. What we're really talking about is the person shows up with chest pain. So you do an ECG. So figuring out what's occurring. Looking at that ST segment, what we're looking for is ST elevation. So the ST segment has kind of a couple of definitive findings, and there's one that kind of rules out seeing like an acute MI. So if it's convex or straight in any kind of direction, then you're thinking that this could be the heart is not getting oxygen, it's dying. If it has a smile or a frown, if it's going the other way, so convex, so it's bending in like a bow, that is non-ischemic. That is like something like heart strain, so left ventricular, right ventricular hypertrophy, or acute pericarditis, because that's also causes a strain on the heart. So if you see concave ST elevation, you're not thinking an MI. If you're seeing an ST convex or straight, so it's kind of bowing out, then you're thinking this is probably a heart attack. The other thing that you're trying to look for is you're looking for the reciprocal changes in two contiguous leads. So AVL and 1, those are both the left side of the heart, and they're higher up on the chest, versus say AVF 2, 3, those are all on the bottom side of the heart. So if you're comparing the two, they're kind of like this. So if you're seeing ST depression up here and ST elevation down here, what it means is that there's an inferior part of the heart not getting blood. So that's an MI. Let's double check. Yeah. So again, looking at this, if it's straight, especially, or if it's convex, think like cardiac ischemia, so MI. If it's concave, it's not ischemia. Check for pericarditis, check for ventricular hypertrophies. Looking at the ST segment itself. So if we're looking at this ST segment, so we have this flat part, and then the Q, and then here we had the R. And then it just goes over to this T wave. So we know this part's the T wave because it repolarizes and comes down. But there's this really kind of subtlety between it going between this straight line and then slightly curving over. That's your ST change. That's your ST elevation. So here it's right there. And then here's the baseline. Then the ST changes here. Here's baseline, probably up here, baseline here, baseline here, baseline here. It's subtle. So you look at the ECG and there's those lines to help you read the vertical height. You look at the PR segment, and so you're looking like, where's the baseline? And then you compare it to where that change in direction is with this. So here to here and here, and then you can see it coming straight down, and then it kind of flexes out of its thing. So probably here, and you can see it's coming across and then go up, down the straight line, and then it curves. So there's your change. So these are, especially here, these are elevated ST. So that's what you're looking for. And if you see it's concave with a smile, consider something else. So ST changes, again, it's talking about this. So we have our QRS complex. You can see this is the baseline they're going from, and then the ST where it changes direction from the straight line to the shift. That's your ST elevation, and we call that the J point. ST segment elevation with infarction will usually contain the following characteristics. Present in 2 or more anatomically contiguous or beside each other leads. So like 1 and 2, 3 and 4, 1 and AVL, those are all beside each other. The ST segment is often flat and upsloping, so you can see it's kind of flat and upsloping here. And it's like, as opposed to being like curved, so like curving like that, or concave upward. And it's rarely / basically never concave and upsloping. So if it's doing the smile or the frown, if it's going the other way, then think strain or pericarditis. It's going to be associated with reciprocal ST depression, the opposite leads. So if it's in the bottom, the stuff at the top is going to be flipped. The higher the ST segment elevation, the higher the probability of infarction. So if it's really high, it's an MI. And when there's reciprocal changes are present, it's really suggestive that's an MI. So if you had two and then you could find it something inverted on the other side, you got it. Oh, and if you see the T wave has changed, so here we have a nice upward going T wave, but if it's biphasic or inverted, it just means it's been more time since the MI occurred. Here you can just read this on your own. It's just a table describing some of the things that's the elevation. Again, you interpret things in context when you do an ECG. Biphasic T waves, you can see them in MIs, you can see them in some other conditions. You don't read these first, you read them after you've interpreted pretty well everything else and use it to back up what you know. STEMIs, so when we're talking clinical findings, it's like the retrosternal chest pain, it's dull, it's squeezing, it's not sharp. The radius to the left jaw, their chest, their arm. They might have breathlessness. They might be sweating, anxious, dizzy, fainting, or they might have a new heart murmur, an S4 because the heart's not contracting. So blood's kind of hitting this wall. So you hear a thud. I think that's all you can kind of look through this. I like how they grouped it. So they have V1, V2, V3, V4, V5, V6, lateral 1 AVF, 2, 3 AVF, V7 through, usually we just say 8 for posterior. So here's an approach to the cardiac infarction. I mean, of course, adapt it to what works best for you. This is how I like to look at it. Infarction, so look through the different segments, lateral, which includes lead 1, 2, and then V5 and V6. Inferior segment 2, 3, and AVF, and then precordial, so V1 through V6. And I like to do them 2 at a time. So 1, 2, 3, 4, 5, 6. So that way I can see the continuity with the 2 changes. You might see peak T waves, you might see inverted T waves, you might see biphasic T waves. You look at them last, don't worry about it. ST elevation with reciprocal ST depression is great. You see that it's very indicative. It should not be concave. That is the big take home. If it's concave, work up for strain, work up for pericarditis. Stop thinking MI for a little bit. Usually it's about box wide. In some areas it's a little bit different, but that's specifics. Q waves, this is a box high for an ST elevation. So comparing the PR to that change in kind of direction with the before the T wave, that's your ST. Q waves, it's about a box wide, a box deep. There are some other criteria. So V1, 2, so when you're going through the precordial leads and the R gets higher and higher, they should have a tiny R before the S wave. Otherwise, if it goes straight to like what looks like an S wave, it's actually a Q because the R is gone. So the way I looked at it is that like it immediately drops from the baseline. The PR, well, if there's no PR, it goes PQ. V3 with R less than S, so R should be getting larger. If they don't, I'll be able to show you on another picture. It could mean an infarct. Inferior leads should always have an R wave. So 2, 3 AVF, all those bottom leads at the bottom of the heart should have an R wave. If they don't, that's a Q wave, not an S. Loss of R wave progression, V1 to V6 is not good. So they should be getting higher. If they don't, probably an MI. And 2 leads beside each other. So there's some other criteria for like the left main occlusion because it's a little bit, it presents a little bit differently. However, we're going to focus on kind of the less serious occlusions. So comparing with like ischemia, because ischemia has ST depression. So ST elevation's the MI because you have the full thickness. So basically it's how the charges look. And then the simple thing to know is ST depression is a partial ischemia. So it's not quite as bad, but it could become an MI. It could go from a partial thickness to a full thickness. And once it goes to full thickness, the tissue dies, and then you have a Q wave. How it looks on here is essentially what's happening is that this part of the cell is not changing its charge as it should. It's not depolarizing, repolarizing. So it's kind of always in the middle. So after contraction, all the cells depolarized, right? So then all the positive charges came in. So this guy here is positive. Everything around the heart is positive except him. He's negative. So what happens is positives like to push towards the negative. That's how I like to think of it, pushes towards it. So it's pushing away from the lead. And so since that's doing that, you see an ST depression. This is more detailed than what you need to know to interpret the ECG. It's just for your interest. So ST depression indicates that it's subendocardial. And the reason why we say it's like subendocardial usually, because that's the area of the heart with highest pressure when you're squeezing to push blood out. It's also the furthest from the coronary arteries because they come around the surface of the heart, then go in. So if you have any area that's going to get ischemia, it's probably the inside of the heart, subendocardial. So right against the inside. And so if you don't address it, then it can become ST elevation, then like a full-on Q wave MI. T waves, they change, interpret them in context. Please don't interpret them first or by themselves. Approach to cardiac ischemia and STEMI. So again, you're just looking through all the leads. It's almost the exact same process. Should be 2 contiguous leads, so 2 areas, and it shouldn't be the whole heart. If it is, it's probably like a left anterior descending or like a main artery occlusion. It's going to be ST depression, so it's going to be doing straight across, or it's going to be kind of going down sloping. If it is got a smile, because it's concave, so concave means it's kind of bowing in, so that the curve is going to like kind of hold stuff towards the, like here. This would be convex. This would be convex because it's pushing towards the line, like this area. This is concave, it's pushing away. And then if you have inverted biphasic T waves, again, you just interpret them in context. You saw all these other things, and then you saw the T wave. Okay, so coronary arteries. So right coronary is V4R, left anterior descending V1, V4, posterior descending or just the inferior part of the heart, 2-3 AVF. You could have V8, V9 maybe. Mirrors V1, V2 for the posterior view, and the circumflex is also caught with V5, V6 as it's coming around if it's supplying back the heart. Left circumflex artery, 1 AVL, and then V5 and V6 are important too. This is what it looks like: lateral, inferior, septum, and anterior, and then lateral. And then we have the lead 2 for rhythm. Here's another picture, same thing. So this is a picture of example cues with ST elevation. So which coronary artery is blocked. So if we look through, I mean, this picture's already got all the answers on it, but you can see that there's this ST elevation from this PR. So PR is down here, but the ST, where it changes direction from that vertical line to the little shift, is higher, and 2-3 end AVF. So that means 3 leads to contiguous MI. Right. So I think one of the ways that we could also describe how you're interpreting the T waves is, imagine if you're getting your history from the ECG. You're getting all your history. What's the rate, rhythm, axis, intervals? What's the hypertrophy looking like? Is there Q waves? You're getting all of that, and then you're using the T waves to kind of just back up what you already know. So if it kind of goes along with it, it helps. If you didn't see it at all, it didn't really help, and it wasn't needed either because you already interpreted what you had from your history. So going through it, Q wave, R wave progression, ST segment, T waves. So you're kind of looking through like ischemia, infarction, strain, or pericarditis. V1 through 6 are going to get the T waves well, but really you're going by region for the whole thing. Lateral, inferior, precordial. Need to see 2 contiguous leads, the ST depression, you're looking for ischemia. A caution is that posterior infarction looks like ST depression in V1, V2. It's a high R wave. One of the ways you could confirm it is get some posterior leads. The other thing is just probably recognized based on symptoms and severity that this is probably an MI. ST elevation, you don't want to see a concave. Loss of R wave progression, looking at the Q waves, probably infarct. So the overall approach, you're more than familiar with this: rate, axis, rhythm. Don't forget the PR intervals, PR, QRS, QT, hypertrophy starting with the atriums and then the ventricles. Looking at the bundle branch blocks for those wide QRSs, and then also the spiky ears, depending where you're looking. Wolf Parkinson's White, so barbecue with, so Wolf Parkinson's White, so kind of a short PR with the inflection before. Q waves, ST segments, elevated, depressed. T waves, are they inverted or just abnormal, not like your usual nice up? So depolarization abnormality is a repolarization abnormality. Get your history, interpret the T waves after. Change in a T wave just means something happened. R waves, looking for progression from V1, V6, and then you're basically just kind of ruling your other things out, strain, ischemia, infarct, pericarditis, something else. So I like having this little table. At first, it's a little bit slower because you're going so methodically through the ECG, which is, I guess, an approach I just like to do. As you get harder and harder ECGs, it saves time because then you're not trying to regather all your information. So how I like to group it is I went lateral, inferior, precordial / anterior, and then I had my interpretation at the end. And then I had the barbecue STR, so Q waves, ST segments, T waves, and then R wave progression. So you should be checking V1 to 6. There should be getting a larger R. And then I just would write down like, is there Q waves here? And I just like put a check. Then were they in the lateral, inferior, precordial, check, check, check. And then ST segment, was it changed up or down? I'll just write up or down. T waves, are they inverted? Biphasic, I just put like an I or like a B. So then I just knew at the end, once I got through everything, I'd be like, oh, there's Q waves in the lateral segment with ST, no ST changes, but the T's were inverted. So my interpretation, if it's the lateral segment, is that this was a previous MI a couple days ago. Done. Okay, so let's see if there's anything in particular in here. Yeah, just make sure you go through each area at a time. Usually I'd look at the lateral area and work it through like Q, ST, T, R waves. Instead of going like all the Qs through all the different sections, I'd kind of go one section at a time. So we're on to practice. So we have a few questions here. And I'm going to pause for a minute. So looking at this question, so we're looking from ECG practice on ischemia. So questions 4, 10, and 9 as well. Question 4, so working it through, looking at heart rate. So 300, 150, 100, and it's over 75. So I'm just going to say like a heart rate of 70. Axis 1 and AVF are up, so normal axis. Rhythm. I actually usually do it intervals before rhythm. This helps, I find. So it looks like PR interval is less than a box, so it's not delayed. There's no AV block, and it doesn't appear super close. So PR is normal. QRS looks normal. This doesn't look wide. So QRS normal, and then QT is less than half. So that's normal. And then now for rhythm, so I'm looking for P's to my QRSs, and it looks like I have 1P, 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 1P per QRS. So it looks like a normal sinus rhythm. All right, so now we're talking about hypertrophy. So state. So hypertrophy, we're looking over here in lead. Left atrium, looking if it's inverted, and it doesn't appear that way. It doesn't appear spiky over here. So there's no atrial hypertrophy. And then ventricular, so we can be looking for left ventricular, so it has to be greater than 35 millimeters or 7 boxes between these two leads. Don't see that, and I don't see a big R over here, so no right, so no ventricular hypertrophy. So rare steak barbecue, there's no bundle branch blocks, QRS is narrow. Wolf Parkinson's White, again, not really the point of this lesson anyway, and I don't appreciate any kind of delta waves or slightly wide QRS. Talking about Q waves, so I like to use the table, but because I'm on the computer, it's kind of hard to pull it up. Yeah, TR interpretation. So Looking through Qs, so we're going to just work through each of the sections. So looking from lateral, looks like there's no Q, no Q. Perhaps a Q, but it's only one spot. No Q, no Q. So no lateral Qs. And if I had the box, I could just do an X. So on paper, this is faster. Inferior, 2, 3, AVF. No inferior. How about precordial? So there's no R here, so that's concerning if that's likely a Q. It's no R again, no R. There's an R, there's an R, there's an R. So 1, 2, 3 are potentially Q 1 through 3. ST segments. So I think I broke my own rule and just went through the whole thing looking for Qs instead of each section. So maybe let's go back a step here. That's why I like the table. It's a little bit more organized. 1, I didn't see an ST change. No. So this baseline looks the same as the baseline after. So no change. 5 and 6. This baseline could be a little bit lower. Maybe not. It looks like it's pretty similar to this line before and after. This guy here, E. I mean, if it is, it's subtle. It could be there. So we could say ST, so lateral ST depression. Of course, we'll interpret this all in context. Looking at T waves laterally, no change there. And perhaps inverted. This has changed. So this looks biphasic. And this one looks, yeah, that one's inverted. So let's just say T biphasic V5, 6. I think that was like kind of the biggest finding there. The other ones are kind of there too, but not as big a deal. So let's do the inferior. So we already did the Q waves. Usually you could just not, I mean, if you're going to screen the ECG, you have to detect both Q waves and the ST segment. So it doesn't help to cut it out. So it looks like maybe pretty similar, perhaps a little bit lower, but not by much. So looks like about 2 boxes below that big line. This one's really about 2 boxes below that big line. So not really any changes. Now we're looking, so no changes inferiorly. And then looking at T waves, that looks normal, that looks normal, that looks normal. So normal inferior. And now let's look at the precordial. So if we're looking at precordial, we're going to be looking at this ST elevation here. We already looked for a Q wave, which we think is there. So it looks like it's up. That looks up. It has to be a little bit higher in V2, V3, like 2 millimeters instead of 1. It looks like it's at 2 millimeters. And this doesn't look like it's elevated. It's maybe a box, but you have to look at where it changes direction. So it's going straight and it changed direction there. So it's actually not really that much different. Here it's straight and not much change. Straight here, 1 box below, maybe 1 or 2 boxes beneath. So I'd say ST elevation V1 through 3, maybe depression V5, 6. And the T waves here up, potentially biphasic, not bad though. So let's leave it. I think that one's probably biphasic. It goes up and it's got a nice dip back. V4 definitely, V5, yeah, V6 maybe. So I'd say like V3 to 6 biphasic T waves. So a little bit overlap because I already interpreted it there, but expanded the field. Looking for R wave progression, it is abysmal. Look at that. No R wave, no R wave, no R wave, tiny R wave, and then we finally get some Rs. That is way too low. So poor. Interpretation. So if we look at this, maybe we could talk all about this, but that's just our first sentence. So we know that everything else with the heart is fine. It looks like we have an anterior V1 through 3, which is the left anterior descending artery. MI or infarct because we have Q waves. And then we can add the T wave interpretation with biphasic T waves V3 through 6. So that's our interpretation of what we just saw. Let's look over here. Anterior Q waves V1 through 3, bingo, with some ST elevation, but T waves inverting V4 through 6. And there you have it. So each of these takes a while to get through. So each of these takes a little while to get through, but if you're systematic, then you're going to get an interpretation that's going to really help what you're doing. And then the T waves, you save it for the end because otherwise it's confusing. All right. Yeah, I don't promise to get 100% on all of these, but we'll do our best. So 300, 150, 100. So heart rate 100. Axis, normal. We are looking for axis. Let's look at intervals. Intervals looks like PR is less than a box, so looks pretty good. Let's look at QRS, looks pretty narrow, looks good. QT, yeah, it looks like maybe half, probably less than half, so normal intervals. Axis rhythms, looking for our P's, so P, QRS, P, QRS, P, QRS, P, QRS, QRS. All right, so it looks like it's 1-to-1, so sinus rhythm. Maybe tachycardia, because if this was like if I had like sometimes the ECGs aren't 10 seconds long, so if you count and then do the multiply by 6, sometimes you don't get the answer that they actually have. So if it's over 100, it's tachycardia. Right, so stakes, looking for hypertrophies. Perhaps a little, no, not enough. Doesn't have that nice dip switch, and then this isn't really big, so no atrial hypertrophy. I don't think there's a ventricular hypertrophy. There's no big signs of that, so no hypertrophy. Rare steak barbecue, so butter branch box, no. Wolf Parkinson, wait, no. Q waves, so QSTTR interpretation. Yeah, just because I'm doing this like on a computer, I might actually just shift my approach to just doing like all the Q waves and stuff. This makes it a little bit easier for me, but I prefer the table if I had the check boxes way faster. Q waves, nope, nope. No, non-lateral, so no lateral. I guess I'm already doing it. ST. Maybe, nope, not lower. Subtle. So this one is like about a box below. This is maybe 2 boxes below. This one, so this is about 2 boxes. This is about like 4. So that looks like an ST depression actually. So I think there's an ST depression, and then V5 definitely is. So ST depression, V5, 6. So this depression, 5, 6, T waves. Nope, nope. Inverted, inverted. So inverted, 5, 6. R wave progression. I'm going to come back to that. Let's do Q waves inferior. Nope, nope, nope. So inferior. And then STs. Meh, pretty flat, pretty flat. This could be, looks like 2 boxes below that line, 2 boxes below that line, so we're good. 2, this looks like a box and a bit. This one looks like 2 boxes straight up. This one's like 1, this one's like 2. So 2 is depressed. The other ones are hard to read, but only 2, so it's not contiguous. So we're not going to put it down because it needs both. T waves. We're looking inferior, so up, probably normal. Yeah, it looks normal. So normal, inferior, normal, inferior. R wave progression. Coming back to that. So let's do our precordials. So looking for our Qs. There's an R. There's an R. It's getting bigger, 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 bigger. So no Qs, but and then there's good R wave. So progression, good progression. STs, no change there, no change there. Again, when I'm looking at the change, I'm looking at this big line, and then I'm looking 1, 2 little boxes. This one's like 1, 2 little boxes to that J point, so it's good. 1 box, 1, 2. There, it's close. It's close, but not by much. So probably not definitive. B4 for sure. This is like 2. This is like 3 or 4 boxes. Yeah, this is definitely so. Yeah, you could say V3. It's definitely on the edge, but I'd say V4 through V6 are my definite culprits for ST depression. And then T waves, normal, 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 still normal, inverted, inverted. So my V5, V6 are inverted. So what is my interpretation? There's no Qs, so there's probably not MI. It looks like we have, so lateral ischemia, V5-6 ST depression with inverted T waves, V5-6. So that's it. That's basically, so it's which equals like a left circumflex artery, a blockage there. So that's my kind of impression from this. Have a look at what they said. ST depression V3 through 6, yeah, subtle. So I would agree. 1 in AVL, fair enough. So I didn't quite go as subtle as they were saying, but it does make sense. This is like 1, 2 boxes maybe, and this is like 4. So yeah, I missed that. And then 2, 1, 2. This is wait, AVL. Yeah, AVL is pretty subtle. So 1, 2. I guess this is 1, 2. It's getting close to 3. Yeah, pretty subtle, but I think over here it's quite obvious. So in context, it makes sense. It'd be a little bit more scrutiny. T-wave inversions, V5-6, totally. Large area of ventral ischemia, ST depression, normalized when pain-free. It had a 3-vessel coronary disease. So there you go. So I was thinking like kind of less circumflex artery blockage over here, but as the person was later found out to have 3 vessels, so there's actually a little bit more to the story. But I mean, it's a good start. Question 9. This one probably has extra additional findings. So let's do it. Heart rate. All right, 300, 150, 175. Axis looks normal. Maybe not. Maybe not. 1. No, it looks like it's actually a right axis because 1 is kind of going down and AVL is definitely down. So right axis. Intervals, pretty close, pretty good. Yeah, cool. All right, good intervals. The QRS looks normal, and also the QT is less than half, and PR wasn't too long. Rhythm, looks like there's always a P before the QRS, and it doesn't look like it's elongated. There's no dropped QRSs, so normal or sinus rhythm, since the sinus node's controlling it. Looking at hypertrophy, for the atria, it doesn't look like it. And then for the ventricles, doesn't look like it. Looks like a right bundle branch block here. So, so we could query right ventricular hypertrophy, and then we have right bundle branch block. So say barbecue, so BB, and the QRS. I mean, if that's, yeah, I think I'd have to re-say like, looking at this QRS, that looks wide. Looking at this one, it looks normal. This one's wide. This one looks wide, and it's got the ears too. So I think that's a right bundle branch block. So I might change it to wide QRS, especially in like V3. Okay. Yeah, skipping Wolf Parkinson's. Moving on to our workup for Q. STTR interpretation. Yes, this is obviously like a long recording. Hopefully, I mean, the basic information doesn't take too long to get through. It's really the workup of the ECG that's slow. Q waves, nope. And maybe, looking over here, V5, V6, probably not. So let's say no Q's lateral. ST, pretty, oh, that's a little bit elevated. That's, yeah, it's maybe a box. That's like maybe a box. This is level, that's a box up. So let's look at this guy. Pretty flat. I'm going to go without that. So no lateral. It could be looking over here. So it's like one box below this line. This is like one, maybe two. This one's like 1, 2, 3 below. This one's 1, 2, 3 below. There's a little dip right before, but yeah, subtle. If it's there, then it's very subtle, and I think it's probably not as important. So no lateral. Let's stick with that. T's look up. Good. So normal T's. So no lateral changes. Okay. Q is inferior. Nope, nope, nope. No inferior. ST changes. 2. I also have this guy down here. So this is like on that line. This is like almost on the line. And just below, just below. Yeah. Yeah, this is breathing, so we don't want to interpret that as a ST change. Looks pretty close, honestly. It doesn't really look like there's a change here, and it doesn't really look like there's a change there, so no inferior. And then T waves, look normal. Okay, now we're on to precordial. So let's just do R wave progression to start. R, 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 R. I mean, this one's really high, but it's probably the right bundle branch block. And it looks like it got higher as we went. I'm going to say normal because it doesn't especially stand out. So this T wave is inverted. So now we're trying to decide. So it looks like it's concave. So that means it's dipping in towards that direction. This looks concave. So this looks like strain because all of these are concave instead of being convex or straight. So what were we at? So no Q's, precordial, ST is the concave. So since it's concave, then strain on the right on the branch block. Let's have a look at STs. It's about the same. It's about the same. Maybe a little bit up. Not by much if it is. And V2 and V3 need a little bit more. So let's be generous there. This one could be up a little bit, but again, it needs to be more. Maybe a bit. Maybe a bit. Pretty even. So much, yeah. So right now it's pretty subtle. So if I was to pick out something, it'd be like this inverted T waves here. And perhaps a little bit of elevation. So it could even be like a posterior. It could even be like a posterior infarct, potentially, because we have this really hard R wave here, so high. And then we have this T wave inversion, both these leads. Yeah, well, let's have a look at the interpretation. Let's see what they say. All right, looks like I was a little bit too generous with my interpretation, but let's have a look at it. Right axis deviation, good. Right bundle branch block. Secondary V1, V2 ST depression with inverted T's. Maybe right ventricular hypertrophy. Right axis, very tall R and V1, yeah. No Q's, so yeah, agreed. But ST elevation V3 through 6. I wonder if this is, honestly, it could even just be the quality of the ECG. This answer has a way better ECG than the question. I'm going to actually take this one and put it over here because that is way more clear. All right, so they're saying, yeah, it's way more obvious with a much clearer ECG than that last one, that this ST is a little bit higher. I mean, yeah, but subtle. So obviously having a good ECG reading is going to really help there. ST elevation V3 through 6. So yeah, that's fair. Yeah, I can agree. And 1 in AVL. So again, kind of picked out like it wasn't quite there, and I was kind of like iffy, but this was the case. And I think with slightly better reading, I think, yeah. Anterior lateral STEMI. All right. And we're on to the last question. So let's do this. Heart rate. Heart rate. Very slow. 300, 150, 175, 60, 50. Heart rate of 50. Axis. Up and up. So normal axis. Just one thing, going back to this one, is that I think one of the things we talked about was clinical context. So if this guy had been showing up with some chest pain, dyspnea, and other stuff, and then you were looking for the findings and you're seeing this little change, it'd be a lot easier because you'd be going, okay, this probably is helping explain his symptoms. Quite often in the test, they'll give you some symptoms so that you kind of are looking for it with that in mind. Axis, so intervals, it looks pretty normal for intervals. QRS looks narrow, QT is less than half, so normal intervals. Hypertrophy, not apparent. Straight axis rhythm intervals. I kind of jumped one there. Rhythm. Looks like a sinus rhythm. Branch blocks. QRS. STT. Q. Then inferior. I'm just going to read this thing and we're just going to move on. None lateral, none inferior. There is some precordial. So V1, 2, 3 precordial. ST, no. Looking in bilateral. Nope. Inferior. No. Precordial, maybe V1. Maybe V2. Yeah, I'd say V1, V2 are kind of elevated. and then V3 through, I think 3 and 4 depressed. T's, lateral T's. Looks like V5 is inverted. Inferior T's, normal, precordial T's, kind of peaked here, but not hugely different. Inverted V3 through V5. So V3 through 5 inverted. R wave progression, poor. Interpretation looks like anterior infarct, V1 through 3 Qs with T wave inversion. Oh wait, with ST slightly elevated, V1 to 2, V3 fork very depressed, V3 through 5 inverted. So that's basically what I'm saying, is it's anterior infarct. Okay, let's have a look at the answer. Heart rate 50, yep. Sinus, oh yeah, bradycardia. Normal axis, normal intervals. Q waves V1 through 3, yeah. Amount of ST elevation V1, V2, got it. No major depression, yeah, fair. T waves inversion bibasic V2 through 5. I said 3 through 5, so close, and then 1 AVL, the head is inverted. I guess so, yeah, they're inverted. So yeah, I guess a little bit of that subtlety just right there. I mean, these ECG printouts I have on the slide could be better quality. I'm not sure if they could be. I don't have any other copies that are better quality, but anyways, so general thoughts. That's Q waves, ST segments, etc. Big section. Great job if getting through it. And yeah, best of luck with the rest of the series.